Hi guys, in this lecture we'll be covering head injury management. So there's two concepts in head injury that are useful to remember. There's a primary injury and a secondary injury. Now a primary injury there's nothing we can do about. That's the structural damage that has occurred to the brain as a result of the traumatic insult. A head injury has a secondary injury, possible though. And the secondary injury is the cascade of events following the primary injury that can worsen the injury. And that's where paramedics can affect outcomes. So this is things like microvascular occlusion, hypoxia, hypotension, things that affect cerebral perfusion pressure. This all forms part of the secondary injury. So really simply, it basically comes down to two things. There are two primary goals in TBI or head injury management that are focused on avoiding secondary injury. The first is to avoid both hypoxia and hyperoxia, and the second is to avoid hypotension. And the reason is that these both dramatically increase mortality. So remember from the other lectures that the brain cannot auto-regulate to maintain its cerebral perfusion pressure in TBI. So that means you need to maintain an appropriate mean arterial pressure to ensure brain perfusion. And hypoxia is obviously going to increase brain damage as it would any other time, but hyperoxia is particularly problematic here. Hyperoxia increases free radical production, as well as causing cerebral vasoconstriction, which is going to cause further damage to injured cells. Now, there are a few other considerations of management beyond those core points. One is that a head injury really means a spine injury until proven otherwise. But we don't want to use rigid collars or rigid full body immobilization wherever we can avoid it. The reason is that rigid collars impede venous drainage, which is going to further raise intracranial pressure. If you do work in a service where you have to use a rigid collar, don't put it on tightly. And where you have them available, try and use a soft collar. Now, if you're looking at an isolated head injury and not multi-system trauma, you can consider raising the patient to a semi-recumbent position at about 30 degrees. And it's going to help, again, facilitate venous drainage from the head and potentially help lower intracranial pressure without compromising the C-spine, because you'll still be keeping the back straight. Now, I touched on hypertension before. We talk a lot about blood pressure. The mean arterial pressure is the more useful reading here. Now, normally in multi-system trauma, we talk about permissive hypotension, which is a mean arterial pressure of around 65. 65 is chosen because that will still provide a minimal level of perfusion to all your organs, but still minimize bleeding. But in TBI, the brain takes priority, and we actually need to perfuse the brain at its normal level to maintain the cerebral perfusion pressure. So we don't use permissive hypotension strategies in TBI. We want to maintain that MAP at around 90, not 65. Other considerations include pain. Even if a patient's not fully conscious, they'll still be reacting to pain, and head injuries are very painful. So make sure to give pain relief, even if the patient isn't GCS 15, and attach a CCP or equivalent, depending on what state you're in, to the case. The head injuries require downstream thinking, and again, this will vary depending on what state you end up working in. So we know that head injured patients and TBI patients will benefit from rapid sequence intubation, and you know they're going to need a CT scan and possibly neurosurgery. So this will have effects both of how much time you're spending on scene. For example, if you work in regional Queensland, you can't provide any of those interventions. But if you work in Brisbane or in most of Victoria, you'll probably have the option to have a CCP or equivalent arrive and perform rapid sequence intubation on the patient. So it may not have that immediate requirement to transport. But if you can't provide any of these interventions, you're going to have to transport fairly early. And just quickly on rapid sequence intubation, it's considered best practice airway management for traumatic brain injury because it allows control of ventilation and oxygenation and helps to avoid that hypoxia that we know is heavily associated with mortality. Now, the difference between an RSI and a cold tube is the use of muscle relaxants. And the reason they're important is if you have a look at this image, there's the glossopharyngeal nerve. Now, the glossopharyngeal nerve is easily irritated by any airway interventions. But the deeper the airway goes, the more it irritates the nerve. So an ETT irritates it more than an LMA, and LMA irritates it more than an OP airway. This is why, unless you can perform the intubation with muscle relaxants, you want to do minimal airway interventions while still maintaining normal oxygen saturations in a head injured patient. If you are able to paralyze them using muscle relaxants, it causes that reaction from the glossopharyngeal nerve not to happen. Now, normally, if you irritate the glossopharyngeal nerve, you will cause an increase, like a big spike in intracranial pressure. So if you can paralyze the patient and avoid that, then you're not going to have that issue. The only other thing, and this isn't a big area in paramedics at the moment, but it might be a space to watch in the future, are current ICU interventions, such as providing hypertonic saline and mannitol. Now, these are just hyperosmolar agents that draw water out of the cells and essentially dehydrate the brain. And as you remember with that Monroe-Kelly doctrine, with the brain being a closed vault, or I should say the skull being a closed vault, anything that we can do to allow more room for that blood is going to cause less damage to the brain. So if we can shrink the brain a little bit, that's going to be helpful. The only other thing is sedation. Head injury patients will normally require sedation. Many ambulance services still use benzodiazepines for this, such as midazolam, but these are not best practice agents, and there will probably be a move over the next several years towards ketamine, which provides adequate sedation in head injury, while still being sympathomimetic, so still helping to support blood pressure, rather than midazolam, which tends to cause hypotension.